Let's talk about induction of labor. I've made an old video all about the process of induction of labor. Actually, let me pull it up because I'm unsure. Okay, so it wasn't necessarily about inductions, but my old video is all about labor and delivery, from when you show up at triage to when you get admitted to when you have your baby and you deliver. So if you want more details on that aspect of stuff, go watch that video. Today's video is going to solely focus on the process of induction of labor. We sometimes recommend induction of labor, what's an elective induction, and then methods of inducing your labor. And I'll also talk about cervical ripening as well. I am currently 36 weeks pregnant. Don't judge my super tight scrub top. I feel like it's just gonna pop. Since I became pregnant, I kind of knew that I think I always wanted an elective 39-week induction, or at least so that I can kind of choose my induction date between 39 and 40 weeks. And I've always felt this way for one reason, and that's because by the time my due date comes, I'm gonna be over the age of 35, and we do recommend an induction of labor for advanced maternal age, or for moms that are over the age of 35 at the time of delivery. Now, do I have to have an induction? No, and I'm okay with it, but maybe I'll do like 39.5-ish weeks. I'm just gonna wait and kind of see. Also, that may not even happen because my baby is breech. So if she's breech, then I'm just gonna have a 39-week C-section. Maybe I'll try and flip her. If you want more details about my personal pregnancy, I will leave that video linked down below where I talk about the fact that she's breech and what I'm thinking. If I'm gonna do an external cephalic version to get her to flip, I still don't really know. If she goes head down, then I would love to induce my labor on December 1st. My due date is December 5th. So I'll be like 39 weeks and change because my birthday is November 24th. I don't really want her to come on my birthday. And Corey and I think it would be cool if she just had her own birthday month. So that's the tentative plan. And if it works with my doctor's schedule and my family's availability, I think December 1st would be a cool date, or like December 2nd. Anyway, we'll see what happens, but enough about me and my pregnancy. Let's talk about induction of labor. Starting right off the bat, what is it? What does it mean to have an induction of labor? If you hear my dogs, like in most of my videos, they just like to join me. I'm filming, huh, Maggie? You just like to be noisy. You're stinky. Hi to the world. So an induction of labor means to use medications or other methods to start uterine contractions so that we get you into active labor. And actually more than 22% of pregnancies are actually induced. Why do we induce labor? End goal is for a vaginal delivery. And there can be a multitude of reasons of why we might recommend an induction of labor. Think of this in two different ways: a medical induction of labor and an elective induction of labor. A medical induction of labor means that we make a strong recommendation because of something that's going on, whether with the mother or the patient or the fetus. So things like preeclampsia or high blood pressure, that can be an indication. Uncontrolled gestational diabetes, uncontrolled type 2 diabetes. It could be that your water broke. It could be that your water broke at 34 weeks or a whole 6 weeks early. It could be that you're post-dates or that you're 41, 42 weeks pregnant. Those are all indications that we recommend inducing your labor. At that point, it's safer for the patient, the mother, or the baby. As always, it's very important to talk to your doctor and figure out why they might be making that recommendation, because ultimately it's your choice whether or not you want to be induced. We can never force you to do something, but if they're strongly recommending it, please listen to the risks and benefits and why they might be recommending that. What's the difference between an elective induction? An elective induction means that there's no real medical indication to induce your labor. It could just be for patient preference. Like I mentioned earlier, for me, even if I wasn't advanced maternal age, which is a medical indication for an induction, but even if I wasn't, I think I would still opt for an elective induction. I haven't loved being pregnant. It's been uncomfortable. And at 39 weeks, the research is there. We know that it's safe for baby. So if a patient wants to be induced, whether it's for discomforts, she's tired of being pregnant. Some patients really want to be delivered by their doctor and it just works out with their schedule. Their patients live really far away, like 2-3 hours away from the hospital. So having an elective induction for the timing and ease of the whole process, they may elect to be induced. Sometimes, and I've done this before with some patients, where the father of the baby is going to be deployed or is in the military and only got a set number of days approved. If the patient's over 39 weeks and has no issues, that could be an indication for an elective induction. I also think it's just empowering to give patients that choice to have control over whether or not they do want to be electively induced. As long as you're safe, as long as everyone is on the same page, I think it's okay after 39 weeks. And the research and the ARRIVE trial, if you want to read more on the ARRIVE trial, that was a research study that was done on elective 39-week inductions. The research is there and it's good outcome. So I will leave that link down below if it's something you want to read. But ultimately, you should feel empowered about your birth and you should feel like you have the choice to make for what works best for you and your baby, knowing all of your risks, your benefits. Ultimately, your body, your choice. That's what I believe. With the process of an induction, there's different methods that we can do to induce your labor. But what really is going to matter is your cervix and what your cervix looks like, what your cervix is doing prior to starting the whole induction process. So let's say you show up for an elective induction of labor or you have preeclampsia and you need to be induced. The first thing that we're going to do, besides like an IV, history, physical exam, all that stuff, we need to check your cervix to see what you're doing. Is your cervix closed? Is it soft? Are you already 1 centimeter dilated or 3 centimeters dilated? That's going to dictate the best method and the best recommendation that we can make to start your induction. Let's say you go in and your cervix is closed, something that we call closed, thick, and high. Your cervix is not essentially ready for labor. You need to start with something that's called cervical ripening to get your cervix ready for the process of your induction. How exactly does the cervix change and what does that mean? I'll insert pictures here to help with my explanation. Essentially, we want the cervix to ripen or to soften. We need the cervix to get thinner and to start to open or dilate. Typically, your own body starts to do this before labor really kicks in. Not for everyone, but a lot of the times your body knows it's getting closer to your due date and closer to labor. So it may start to do these changes on your own. It may not. Everyone is different. But luckily, there are things that we can do to help ripen your cervix. And we can do this by 2 different methods. It's going to be with medicine, things that are prostaglandins, or we can do mechanical cervical ripening. Cervical ripening with the use of medicine is through the use of prostaglandins. And these are medications that can be given either orally by mouth or they can be placed inside of the vagina. It's going to be best for you, just depends on your whole clinical picture, and I'm sure hopefully your doctor or your midwife is going to explain this to you, but I'll differentiate. If you're doing cervical ripening by mouth, this typically looks like a medication called misoprostol or Cytotec, and it's a pill that you just take by mouth, and it works to release It works to help soften and thin out that cervix. You may start to feel cramping and uterine contractions when you take that medication. That's very common. That's the whole goal, so that we can prepare your cervix for the induction. We can also use prostaglandins or that same medication called misoprostol or Cytotec and place it inside of the vagina. Usually it's a small little tablet and your nurse or your doctor can place it up by your cervix. It is absorbed through the vaginal tissue and the cervix and works the same way to help soften and ripen the cervix. There's also different medications. One is called Cervidil. It looks like this tiny little thin tape, as you can see in the picture, which is inserted vaginally, and that can stay in place up to 12 hours. And there's also the option of using a vaginal gel for cervical ripening. I would say the most common option is probably going to be Cytotec. It's been around for years, and I would say most practitioners use this medication a lot for the process of cervical ripening. But again, it's just going to depend, patient preference, doctor preference, whatever. Now, when we talk about mechanical cervical ripening, this looks like a Foley bulb, and I'll insert a picture here. There's 2. There's like the old style Foley bulb that looks like a Foley catheter that we would place inside of the urethra and the bladder. And there's a new one called the Cook's catheter. Both work the same way. They're both placed the same way. But essentially, to have a Foley bulb placed, you have to be at least 1 centimeter dilated. But essentially, you take that catheter and you're placing it through the cervix. The other side of that catheter, you're gonna blow or not you, but me as a practitioner, will fill up that little balloon with saline or water. That balloon is going to put pressure on the cervix to kind of mimic the baby's head, as if something's putting pressure on that cervix, so that the cervix starts to thin and also dilate. Foley bulb can stay in place for up to 12 hours, or sometimes they fall out on their own. Once you get to about 4 to 5 centimeters, or the diameter of that little balloon, it'll just kind of fall out. These are uncomfortable to place. It feels like a very long cervical exam, or when you get your cervix checked, and they can be pretty uncomfortable because it is going to cause cramping and discomfort. Now, when the Foley bulb is in place, you can still go to the bathroom, you can still get up and walk around. You need to have an epidural when it's placed. You can request pain medication before placement because it is pretty uncomfortable. They do work really well. Make sure to talk to your doctor about it. Ask them to walk you through the whole process. Ask them to make recommendations on whether or not you should take pain medication beforehand, because every patient is different. The other thing that we can do is, with the placement of the Foley bulb, we can actually place it with misoprostol or Cytotec, that same medication. And sometimes when you use both of them together, they work really, really well to really ripen your cervix and get things going. You could also place the Foley bulb and also start Pitocin through an IV to work together to help ripen your cervix and get those contractions to be just a little bit stronger. So now you've gone through the process of cervical ripening, what can we do to continue on with your induction? There are all going to be methods of inducing your labor. If you didn't have to have cervical ripening, like let's say you showed up to L&D and you were already 3 to 4 centimeters and your cervix was soft and ready, then we didn't have to do cervical ripening and we could just jump into these methods. One is going to be membrane stripping. Very common way to start a process, but surprisingly, membrane stripping is not something that needs to be done in the hospital, and you can actually have this done in the office setting. I've done it for my patients in the office setting as a way to kind of help kickstart labor. It's not with the use of medications, it's actually when we check your cervix. Say you're already 2 centimeters dilated, so you're like this. It's a way to kickstart labor by separating the amniotic sac from the cervix. Now, yes, this is going to be uncomfortable because anytime we touch the cervix in pregnancy, it's going to cause some sort of discomfort, cramping, just generally not great feelings. But the way this is done is by placing one finger through the cervix so we can feel that amniotic sac, and we gently sweep. It's also called membrane sweeping. But we sweep all the way around to separate that amniotic sac from the cervix. This is going to cause a release of prostaglandins from the cervix to help start contracting, to help soften the cervix even more. So again, it's a great option. Another way we can start your induction is by rupturing your membranes or doing an artificial rupture of membranes. AROM is what we call it. By breaking that bag of water, if you're already contracting, it's going to make your contractions stronger typically. And if you're not really having strong contractions, if you're not really contracting that much, then it may start to really gear up some of those strong contractions. I actually have an Amni hook with me. I've had this for a while, but this is the device that we use to break your bag of water. As you can see, it almost looks like a crochet hook, and it is just plastic. It's not very sharp, so it's not going to cause any sort of pain to you or to your baby. Again, you have to be dilated to do this, but essentially when I do a cervical exam, I'll check to see how far dilated you are. And with the use of this instrument, I will insert it through the vagina, through the cervix. Once I get to that bag of water, I use that little tip to kind of hook the bag of water and then cause it to break. Again, the process is not painful. What you will feel is that warm amniotic fluid come out. So it's gonna feel like you peed yourself, and you can expect that amniotic fluid to continue to leak out until your baby is born. I would say the most popular method that people talk about is going to be using Pitocin. Pitocin is a medication that's given through an IV, and it is a synthetic or a man-made form of the hormone oxytocin. So your body actually does release oxytocin to help start labor and get contractions going. Pitocin is what was made, and it is the exact same molecule as oxytocin, works in the same way, but we're able to give it through your IV, get those contractions stronger, and to continue on or start your induction. It may take about 30 minutes before you actually start to feel the contractions or feel any sort of discomfort. Everyone's a little bit different, but typically I would say within 30 minutes you can expect to see it start working. Lastly, another method that's not as traditional because the studies aren't that great, but you can attempt it, is actually doing nipple stimulation as a method to start an induction. Now, back in residency, one time there was a shortage of Pitocin throughout our hospital. So we didn't have all that much Pitocin, and we had to kind of pick and choose which patients were going to get it because there just simply wasn't enough. Obviously, we have to keep in mind that we also use Pitocin to help stop postpartum hemorrhages. So it was kind of a cluster, but essentially on the patients that were okay with it, we actually recommended nipple stimulation. By stimulating your nipples, it actually causes a natural release of oxytocin that can then lead to contractions. Now, it's hard to say which patients this is going to be actually effective on because, again, the research isn't that great, but it is an option. And so we gave that option to patients. They wanted to do it, if they wanted to have their partners do it. So some of them use like a breast pump to start that. So it just really depends. I just very vividly remember that in residency. Yeah, there was a shortage. We had no other options. With the data on nipple stimulation, this only really proved to work well if the cervix was already favorable and ripened and soft and ready. Otherwise, if it was a cervix that wasn't really favorable, it doesn't work very well. Those are going to be the main methods that we can use to induce labor and to induce cervical ripening. Now, keep in mind, each method does have their own risks and benefits, so it's always important to talk to your doctor about it. If you guys want more details on like the full risks with each method, please let me know and I can make another video. I hope you enjoyed this video. I hope you learned something and that maybe it helped put your mind at ease if you're going to have an induction of labor, or if your provider mentioned cervical ripening or whatever it may be, whatever your situation. I hoped this helped. As always, thank you so much for all of your support, all the love. Please leave any questions down in the comments. I am pretty soon going to be in a similar situation of induction or maybe C-section, depending on what this baby girl decides to do. If she doesn't flip, we will see. I'm doing everything to try and get her to flip. We'll see you guys next week for a new video. I love you and I hope you have an amazing week. Bye.